Second presentation is regarding non-compaction cardiomyopathy, which will be delivered by Dr. Gobinda Kanti Paul, who is working as a head of the Department of Cardiology, Mymensingh Medical College.
Have a nice good morning, everybody. It's my immense pleasure to be here in this August gathering. Honorable Chairperson, panel of expert, moderator, and learned audience, and all the dignitaries. My presentation, more show, less talk. It's a case presentation. A long journey from a maturation failure to heart failure. Mr. X, 52 years, old male patient, gradually increasing shortness of breath and having bilateral pedal edema and functional class NOH class 3-4. And pulse 55 per minute, blood pressure 115/75, bilateral pulmonary rales, distended abdomen, and bilateral pitting edema. And precordial examination, the striking finding, pansystolic murmur, grade 3/6 in tricuspid area. The ECG show wide complex QRS and LBB pattern morphology. Chest X-ray shows dextroposition or dextrocardia and cardiac shadow enlarged in transverse diameter and pulmonary congestion as well. Here, modified parasternal lungs view. The prominent is the left ventricle here. There is a pretty good, the multiple trabeculation near the LB apex and also the part of the septum, and also color flow intertrabecular spaces, and also small amount of pericardial effusion as well. Here also loss of inspiratory call-up significantly in inferior vena cava, and also there is a echo dropout interarterial septum, and a color passes, and there is a mosaic flow across the tricuspid valve due to tricuspid regurgitation. And on also mitral regurgitation as well. Here are the still echo pictures. There is a color flow across the interarterial septum, the three picture, and there is a well visualized multiple trabeculation and intertrabecular recess. That means the non-compacted part. And there is a compacted part is very thin. Loss of inspiratory collapse in inferior vena cava. Here shows the spectral dispute due to tricuspid regurgitation and trabeculation, multiple trabeculation. Here the measurement, very much typical. There is a non-compacted part around 21 millimeter and compacted part 5 millimeter. Here, previous one is the right ventricular measurement. Here is the left ventricular measurement. Here also the same things. The non-compacted part is the large, and if you compare with the compacted part. Here, 3D echo. It is very much clear here. There is a multiple trabeculation. Raised, very much raised NT-proBNP, more than 3000. So diagnosis, the heart failure due to biventricular non-compaction cardiomyopathy with aged second arm with moderate to severe tricuspid regurgitation with mild MR with mild pericardial effusion with dextrocardia and functional status during Ditcher's NOA class 2. Ventricular non-compaction is an exceedingly rare genetic cardiomyopathy. The prevalence of LVNC usually 0.09% to 0.3%. And prevalence of LVNC being higher in patient with heart failure, reported it was 3 to 4% around. The phenotype, it may be isolated or it may be associated with other congenital heart disease like ASD or other shunt anomaly, or some neuromuscular disorder, mitochondrial disorder, metabolic disease, genetic syndrome like birth syndrome, etc. Here are the two criteria, Jane criteria and also Chin et al. Criteria. Here are the Chin criteria. It is the diastole measurement of the non-compacted. There is a intertrabecular space and also there is a thickness of the compacted part. Here is the Chin criteria. Here is the non-compacted part, total compacted and non-compacted, and X is the only compacted part. This is the ratio. Here the ratio non-compacted and compacted more than 2, and the ratio X and Y usually less or equal 0.5. Usually at least 3 trabeculation usually must have present, usually 3 trabeculation, and intertrabecular spaces and ratio and color flow through the intertrabecular spaces. Here the sensitivity, when we consider the Chin criteria, that 79% sensitivity, and Jane criteria 64%, and Stolberger criteria 53%. It is usually CMR criteria.
Soft reminder, 30 seconds left.
Peterson criteria, whose ratio in diastole non-compaction to non-compacted myocardium usually more than 2.3. This is the LV hypertrabeculation may be a reversible condition in pregnancy, athletes, sickle cell anemia, and renal failure as well. This is the diagnostic algorithm. It's very much clear or pretty good in the 2D echo. It's enough for diagnosis. Usually not required as CMR usually. Definite diagnosis usually not clear cut. There is no clear cut diagnostic criteria that guideline.
Thank you, Dr. Gobinda Kanti Paul, for your beautiful presentation. And now I'm request Professor Abdullah Shafi Mojumdar sir to give his remarks regarding this.
Thank you, Dr. Govinda, for your nice presentation of a very uncommon conditions. Though it is very uncommon conditions, but for the echocardiographers, it is very interesting. And to them, it is not so uncommon, who are the committed echocardiographers. So your presentation will enlighten the audience about the conditions, and which we may miss sometimes if we ignore the criteria of the diagnosis of the non-compaction. Thank you, Govinda.
Thank you, sir, for his valuable opinion.